the session objectives will be to review the Medtronic Intrepid system for mitral and tricuspid valve replacement, and also to have an update on the early feasibility studies. We're going to review cases both where it's used for transfemoral mitral valve replacement and tricuspid valve replacement. And then furthermore, we're going to discuss future directions for these therapies in Europe. The program is like this. Thomas Modin is going to give a review of the Intrepid system and an update on the ongoing studies. Then Firas Shah is going to show a case with mitral transfemoral early feasibility study. And Vinny Babat and Asim Latib is going to show a case where the Intrepid system is used in the tricuspid position. Then we're going to have a discussion. So let's start with the first talk by Thomas Modin.
Good morning. It's my pleasure and honor to present here today a review of Intrepid TMVR and tricuspid transcatheter valve replacement system and study updates for EuroPCR 2021. So these are my conflicts of interest. I would start by the Intrepid program overview. The Intrepid valve is based on a design which allows for conformable outer stent that anchors without leaflet capture or need for rotational alignment. It has also an inner stent of 27 millimeter 3-leaflet bovine pericardium. It has atrial flexible brim that helps the anchoring during and imaging assistance during the implantation. It doesn't have an atrial protrusion or profile. This is very important for to confirm in the atrial anatomy. And today we have two sizes available, which are 42 and 48 millimeter valves. And there is a XL valve, which is coming under development. So the Medtronic Intrepid clinical program today is more than 300 patients treated thanks to this technology. And there is a growing clinical experience in mitral and recently in the tricuspid space. So the experience with the system is very recent. It started effectively in 2017 when the Apollo pivotal clinical trial was initiated. And these 300 patients includes different steps of studies, the Intrepid pilot, but also the Apollo pivotal, and recently the mitral transfemoral early feasibility study, but also the tricuspid transfemoral early feasibility study. So there's a growing interest and the clinical experience that is accumulated. That has helped thinking, working, developing the next generation of the systems that will be available for us as physicians to treat our patients. So yesterday we had the Gen 1 Intrepid. The design has slightly changed, but mainly the deliverability has changed also. So now we have a recoverable transapical system using the second generation of the valve itself. We have a 35 French transfemoral system that is used for both mitral and tricuspid in the early feasibility studies. And there is a new generation of devices which is coming. We using a 29 French. This is going to be breakthrough innovation with the XL valve that could be an answer for a certain percentage of patients which are not eligible today because of large annulus and the access. So there is growing evidences that could help us understanding better the studies, the results that we have today. So if I go to Apollo trial overview today, we have been able to consent more than 1,000 patients so far from more than 65 studies. And this has allowed to enroll in the Apollo trial more than 200 patients. So it's accelerating actually. So there's a large and growing globally clinical experience. The patient selection is very rigorous, and that's could explain the difference, the gap between consented and enrolled patients, because patients go through a meticulous pre and post-operative care initiatives, and because we wanted to assess the safety but also the efficacy of this system. So the Apollo trial design today is the following. There is a primary cohort that's going to enroll between 250 and 550 patients with the TMVR. There's also a MAC cohort. We will have a discussion about it, but there is also within this trial a roll-in subjects that could be included and treated with a primary endpoint for the primary cohort, which is hard outcomes, all cause of mortality or heart failure readmissions for 30 days of the operation, or the QCC QM improvement, which is very important because we're talking about quality of life and not only treating a disease. The primary endpoint for the MAC cohort is all cause of mortality or heart failure hospitalization at 1 year. This is a slide that shows you that the inclusion criteria for the MAC cohort is either patients with moderate to severe or severe mitral regurgitation with the presence of MAC, or patients with moderate MR and mitral stenosis with the presence also of MAC. These are very challenging patients that are difficult to treat even by surgery. And the MAC cohort is also supposed to enroll more than 250 patients with an endpoint of mortality or heart failure readmission at 1 year. We are happy to announce that the Intrepid Transfemoral program overview is very encouraging, actually. So we have a delivery system, which is today a 35 French capsule, but we are the 29 French capsule is showing. We use the second generation implant. We have a very sophisticated loading system and other accessories, a cradle and the stool, that make your the procedure much easier. As you can see that we have an outer flex and an inner flex that helps you navigating at the level of the septum. But once you have crossed and you're in the left atrium, it will be much easier for you to position the valve in the middle of the mitral annulus. The Intrepid Transfemoral system for the mitral study has started already. 30 patients will be enrolled from 11 sites in the US. We will be studying and examining the safety and the performance of this device. And there will be a lot of information that will be gathered and accumulated from this EFS in order to improve technical developments of what's going to happen tomorrow with the next generation. The same for the Intrepid Tricuspid Transfemoral program. 15 patients from 11 sites will be enrolled. We will be looking at the safety and performance, and we will be accumulating the results in order to understand better and direct research and development. The early experience with the tricuspid system is really encouraging, and the features are very important. Indeed, Intrepid in tricuspid valve is interesting because it anchors without leaflet capture. You need just a minimal oversizing, so this will decrease necessarily the pacemaker rate if ever it happens, and it doesn't have an atrial protrusion or profile, and this will reduce the risk of thrombosis. So the features of this valve from the mitral to tricuspid are very interesting and encouraging, and it's obvious that we could have been translating the mitral experience into the tricuspid. Thank you very much.
Thank you for the honor of privilege of being at EuroPCR this year. I will be discussing an early feasibility study using a Medtronic Intrepid TMVR Transseptal system in a recent case that we've performed here at Oregon Health and Science University. This is my disclosure slide. The case that we will be discussing is an 80-year-old gentleman who has a BMI of 24, who has moderate to severe mitral regurgitation, class 2 heart failure, and relatively elevated STS risk of around 4.8%, with some frailty element that made him high to extreme surgical risk. And we believe that a 48 millimeter Medtronic Intrepid Transfemoral Transseptal valve would be the best option for him. As you can see, he has mildly decreased left ventricular ejection fraction with mild dysfunction in the RV as well. His non-invasive hemodynamic assessment were relatively benign and mildly elevated filling pressure. This is a baseline transthoracic and transesophageal echocardiogram, and you'll notice there are multiple jets across the mitral valve with collective moderate to severe mitral regurgitation. This jet's thought to be complex, and this patient was attempted with an edge-to-edge repair with another institution. However, the procedure was aborted given high gradient after deployment of the mitral clip. Therefore, he was sent to us for consideration of the Intrepid valve. And the primary etiology of his mitral regurgitation is quite complex. There is a anterior leaflet pathology, as you can see here with the arrow on the left part of the screen, thick and calcified component of the anterior mitral leaflet, as well as a component of dilated annulus. The CT analysis is key in assessing valve sizing, and we were able to calculate a mitral annular perimeter of 127 millimeter, and then gave us about 16% oversizing for a 48 millimeter Intrepid valve. Also, by placing the virtual Intrepid valve in the 3D CT, we were able to calculate and predict the LVOT. You will see that the minimal NEO-LVOT was 1.1 centimeter square. However, when we did the multiphase analysis using all cardiac cycles, you will notice that at early systole, the NEO-LVOT area was 2.2 centimeters square, and the average NEO-LVOT using all part of cardiac cycle was 1.8 centimeters square, and we felt that this will be adequate to have a safe deployment without serious risk of LVOT obstruction. Via the right femoral vein, we perform a Transseptal puncture under TEE guidance. We are extremely meticulous in where we puncture the septum. We try to achieve at least 4 centimeters above the mitral plane to have room to maneuver the valve into the mitral annulus. And in this case, we were able to achieve about 4.7 centimeters above the mitral plane. We try to be as posterior as safely possible. And after we perform the transseptal, we dilate the intraatrial septum using a 14 millimeter balloon, as you can see on the right side of the screen. After that, the pre-curved sheath was advanced via the left femoral vein cut down into the over a Lunderquist wire that was placed in the left upper pulmonary vein, and then the delivery catheter is placed into the sheath, as you can see here. After the delivery catheter is in the left atrium, we retract the sheath partially to expose the brim in the left atrium, and then we confirm that the delivery system position is in the left atrium before we withdraw the sheath. After that, we navigate the delivery catheter across the mitral valve and try to achieve as coaxial as possible to the mitral plane annulus. And as you see here in this picture, this is where position of the brim, and it's way above, the mitral valve. This is the capsule, where the capsule is as coaxial as possible to the mitral annulus, both on the anterior posterior as well as in the medial aspect of the mitral annulus. After we achieve the ultimate position of the capsule, we expand the brim in the left atrium. At this point, the hemodynamics are stable as the brim is above the mitral valve and there is flow around it. Also, at this point, very minimal adjustment need to be made to assure that we still have coaxiality of the Medtronic Intrepid valve across the mitral annulus. And we do that on biplane imaging, and we find that MPI also helpful to make sure that we have coaxial deployment. Once that is achieved, we rapid pace to achieve annulus standstill and to be able to have a steady deployment of the Intrepid valve. We then advance the valve under TEE guidance, and once we feel that we have contact with the annulus on both medial-lateral as well as anterior-posterior aspects of the annulus. We then deploy the valve under rapid pacing. The rapid pacing will, in this case, took about 24 to 26 seconds. So it was relatively stable, and the device position was stable. As soon as the valve is deployed, the rapid pacing stopped. The valve functioned immediately, and the patient was hemodynamically stable. We removed the Brim sutures. We closed the capsule, and then we navigated the capsule back through the valve into the left atrium. At this point, we assess the Medtronic Intrepid valve placement, and you will notice that the valve was deployed on target within the mitral annulus. There is no perivalvular leak in between the annulus and the Intrepid valve, and there is trace to mild valvular regurgitation. We remove the delivery system across the transseptal, and we assess whether or not we need to close the intraatrial septum. And in this case, the shunting was not significant, and the intraatrial septum coiled back on itself, that we did not feel that we need to close the intraatrial septum. This is a 3D en face image for the Intrepid valve, and you will notice that the outer fixation ring conformed very well to the annulus, and there was minimal mitral regurgitation centrally. The hemodynamics of the valve were perfect, with a mean gradient of 3 millimeter across the newly implanted mitral Intrepid valve and a peak gradient of 7. And the LVOT, as predicted by the CT analysis, showed a mean gradient of 2 millimeter and a peak gradient of only 4 millimeter mercury. The patient was hemodynamically stable, was extubated on the OR table after the procedure, moved to the ICU, and was discharged a few days after the hospital with excellent recovery. Thank you.
Thank you for the opportunity to discuss a case which was the first case in the early feasibility study of the Intrepid transcatheter tricuspid valve device. These are my disclosures. This is just to highlight the clinical assessment of the case and the planning of the case. As you know, that the Intrepid device has been used extensively well in the mitral position, and it has also been used selectively in the compassionate cases in tricuspid. And the EFS study has now started enrolling in the United States. This is the first patient from University of Michigan, age 82 years. As you can see, a relatively normal Western patient, 172 centimeter height and 68 kilo with a BMI of 23. He was NYHA class 3. And as you can see on the echocardiogram, this is a very interesting pathology, as the tricuspid regurgitation happened to be torrential and the mechanism was primary. The primary pathology was the leaflet, which was prolapsing and which led to severe TR and slow but definite deterioration of patient's symptoms, as well as dilatation of the right ventricle and reduction in the RV function. Left-sided ventricle was normal, ejection fraction of 67% with a good cardiac output. And you can see that the right heart catheter values here, which are not exactly alarming. This is to highlight the pathology, which is a primary TR. You can see septal leaflet prolapse. It's prolapsing into the right atrium. This is pretty unusual in terms of what we see. And also you can see the functional parameters, including TAPSE. And one good thing here for the device delivery is the right ventricle is good size. As the Intrepid device, the capsule moves forward towards the right ventricle. So in all, the assessment was quite favorable. We were initially slightly concerned if the engagement between the tines of the device and the prolapsing leaflet will be adequate or not. As we know, again, the regurgitation level is torrential. This is probably grade 5 regurgitation, which is much beyond severe, and hence, rightly so, symptomatic patient with severe tricuspid regurgitation with RV dysfunction and dilatation was considered for intervention. Again, to highlight the fact that the mechanism of TR is primary. The CT sizing was conducted, as we know, again, the Intrepid is available in 2 sizes, 48 millimeter device being the largest. There's a lot of conversation about the oversizing needed for tricuspid device as against the mitral. As the closing pressures are much less on the tricuspid side, anything between 8 to probably 4% oversize is adequate. As you can see, the oversize here by perimeter is 4%, and the perimeter oversize is around 7%. CT scan analysis is important, as we have learned now through many tricuspid procedures that the IVC approach and the tricuspid may not be in the same 3-dimensional plane. This is just to highlight the amount of reverse towel squeeze you have to put in on the delivery system to get coaxial to the tricuspid plane. This is quite important. The delivery systems at present are large, however, can be maneuvered very well with the different torsions you can put on the inner and outer guide. The delivery system navigation steps are now pretty standardized. The goal is to maintain the guide and the sheath in the right atrium. This is to avoid getting the capsule snagged into the fossa, for example, or going towards too close to the septum. Initially, the guide wire is placed in the SVC and the sheath is advanced. The dilator is removed and then the delivery system is advanced through that. You can see it very nicely here that the capsule is very nicely visible and the X-plane is used throughout this procedure. The initial crossing of the tricuspid valve, of course, on the fluoro appears pretty easy because it's a 2-dimensional, but this is entirely guided by MPR views or even at times biplane views. Multiple views are used by echocardiography, including transgastric views at times. But here you can see that by applying a reverse towel squeeze maneuver and manipulating the inner and outer guide, the capsule is directed coaxial to the tricuspid valve. As you know that the Intrepid device is a 48 millimeter device, it's going to expand, and hence if you are slightly biased towards one side of the annulus, it is okay. As it expands, it centralizes very nicely. Here you can also appreciate in the echocardiography view, the septal leaflet prolapsing in the right atrium. But we believed at that time that when we will expand the brim, it will get trapped below into the ventricle and provide adequate fixation. Intrepid device again has got multiple fixation mechanisms, one being the tines engaged with the leaflets, the other being the cork shape of the device, which engages with the annulus. The next step is expanding the brim. The brim really proves to be a friend during this procedure. You can see the brim is beautifully visualized, not only on the fluoro, but on the echo. Again, for tricuspid annulus, right coronary can be used as a landmark, but many times it is not perfectly aligned with the annulus, and hence echocardiography is critical during these procedures. You can see again in the MPR views, both biplane views, you can see the brim very beautifully seen, and the septal leaflet is flapping up and down. We are pretty happy with this positioning. Here now the catheter is advanced. There's a mechanism in the delivery system by which you can advance the delivery system in and out to check your depth. This maneuver was used, and once we were happy, ventricular pacing was achieved with a wire in the left ventricle, and slowly the valve was deployed. You can see the trajectory of the capsule is towards the right ventricular apex. And again, on the echocardiography, which proves to be very critical in these procedures, you can see a very beautifully aligned tricuspid valve. The next step is catheter removal. Again, this is done under equine fluoro guidance to close the capsule with a bumper and then gently reverse the maneuvers and retract the capsule into the right atrium and then resheath it and then remove the delivery system as well as the capsule through the venous access. Once the delivery system is removed, a detailed assessment of the tricuspid valve was done. There was no paravalvular leak, trivalvular tricuspid valvular regurgitation, which is not uncommon in a pericardial valve, a peak gradient of 2 and mean gradient of 1. A patient was discharged post-op day 1 with a mean gradient transthoracic of 3 millimeters. And you can see a very well-functioning device. So just to summarize, this is an 82-year-old high-risk patient with a primary tricuspid regurgitation, was considered high risk for surgery because of other comorbidities, had a very good but unusual anatomy and physiology in terms of primary TR, was suitable for a 48 millimeter Intrepid transcatheter tricuspid valve system, and was delivered successfully using fluoro and echo guidance and was discharged on day 1 and is currently doing well and is being optimized with medical treatment. Thank you.
Hello, and welcome again to this Medtronic session on the Intrepid device in mitral and tricuspid. My name is Azim Lateeb, and these are my conflicts of interest. Thank you, Vinny, for presenting that great case of an Intrepid tricuspid valve. I think the case really highlights, some of the really advantages and how promising this technology is going to be for tricuspid. So I think you saw a really challenging case with a flail leaflet, which could have been treated potentially maybe with transcatheter edge-to-edge repair technologies, but would have been very challenging. And the risk would have been a long procedure with some residual TR. Here you saw how valve technology could treat this. And I think the Intrepid has really some very important advantages as far as being a tricuspid valve device. So I think, first you saw it is transfemoral. Currently, the sheath size is still fairly large, but Medtronic is working on a newer system that will have a smaller sheath size. You saw how really the delivery system allows you to put the valve coaxial as much as possible to the native valve. And one of the things we've learned also is the importance of using 3D MPR. You saw those pictures. The 3D MPR really allows you to understand the coaxiality, the position, and the trajectory of the valve, because you now have two pictures where you can see the septal lateral and the anterior posterior and really fine-tune the device. I think you don't see from the case, but also I can tell you from the cases that have been done, patients really are stable while you're doing this, and there's no hemodynamic issues. And then you saw, as we release the Brim, you really push the device down, it engages the annulus, and then releases in position. We've been doing that with some rapid pacing. Whether that will always be necessary in the future, I'm not so sure. But I think the final result in the 30-day outcomes are really what's most impressive about this technology. The fact that this patient really has no PVL and no residual TR. So I think we all remain very excited as we continue to treat patients in the Intrepid early feasibility study. We learn with every case. Some of the cases that have been done include patients with pacemaker leads across their tricuspid valve, which we all know can be very challenging, both for repair and some valvular technologies. And I think as we continue to do more cases and learn, this technology is going to be extremely promising for treating tricuspid regurgitation, both primary and secondary in the future. Thank you for your time and attention.
So I think this was some very good talks about using transcatheter valve replacement in both the mitral position and the tricuspid position. Maybe I can start asking you, Gigi. We have seen that patient selected for transcatheter mitral valve replacement It's been a very difficult process. Most of the patient has been turned down. It's been difficult to find patient who's actually suitable for this procedure. Partly because it's a transapical approach, and particularly patient with functional mitral regurgitation has been screened out due to poor LV function. How do you see that is going to change if we can do the procedure as a transfemoral transseptal approach?
So it's true, Lars, that this remains a major issue when it comes to transcatheter mitral valve replacement. The degree, the rate of patient being turned down for the procedure after having been screened through echo and sometimes CT, and then you go for the final assessment and they are turned down. And it's I do believe that moving from the transapical access to a transfemoral transseptal puncture transseptal access site is going to make a difference. But when we see the main reasons for being rejected from this type of procedure, LVOT obstruction remains one of the major factors. So I still believe that this is not going to change dramatically. We are getting better at understanding who is going to be at higher risk of LVOT obstruction after such a procedure. So the more we learn, the more we're going to be able to select the appropriate patients. But there will be still that proportion of patients not suitable for this procedure. So we will need something else in the future, whether it be technology refinements or potentially combinations of procedure just to get rid of that obstruction with the anterior mitral leaflet, for example. So this is a very important question. It's still a burning issue. Moving from transapical to transseptal is going to make a difference. Is it going to be a big difference? I don't think so, because LVOT will remain one of the obstacles.
So it seems CT scan is a very important tool for screening for these patients, to find patient who's anatomically suitable. If you go for a transfemoral transseptal approach, is there something else you need to take into consideration? The size of the interatrial septum, the size of the left atrium, is it going to disqualify a large proportion of the patient for this access route?
Yeah, that's a great question, Lars. Clearly, as you heard from Didier, we need to know about valve size and the anatomy in LV outflow tract obstruction, but we have to remember that these are large delivery systems right now that need to get there, right? So we need a large enough atrial septum with a large enough fossa. We need to have sufficient height from the annulus so that when you actually go across and you start turning down, you have that height above the annulus to allow you to make your maneuvers. That's information we can get from CT scanning. And then probably we forget, everybody thinks of the venous system as this big dilated system that you could stick any size sheath in. That's not true. We've now, even with tricuspid, where patients have all this backflow, we've had patients where the venous circulation is not large enough, okay, to accommodate a 40 French delivery system. We've also seen other things by doing the CAT scan. So I have patients we've had to exclude from a research device because they had an inferior vena cava that was very tortuous. They crossed onto the other side and then came back. Okay, so it didn't stay on the right. It crossed to the left and then came back. We've had patients who, for example, the patient didn't remember and tell us that they had an IVC filter. And then when we looked at the CAT scan, we saw the filter, which doesn't always exclude a transvenous procedure, but there's so much more information that you gather from the CAT scan that's not just about the annulus.
So Didier, the Apollo trial has been changed a few times, and for the time being, it's a single-arm study. That's meaning it's not going to be compared with edge-to-edge repair, which today is a dominated transcatheter therapy for mitral valve intervention. How do you see this is going to place transcatheter mitral valve replacement in the treatment algorithm for this patient when you don't use, the standard of care treatment today for these patients as part of the study?
Yeah, it's true that we all believe in the technology. So we all have this gut feeling that TMVR is going to be part of the armamentarium that we're going to be able to use for our patients. So you're fully right, Lars. The idea will be to find out what is the appropriate place for this therapy to treat our patients. So we all have experience with the edge-to-edge therapy, and we are still struggling with some patients for which the anatomy is not suitable. It's not perfect for an edge-to-edge therapy. So I think that even if we don't have that comparison with the edge-to-edge in a large randomized trial, that would be the best approach to assess the clinical outcomes after the a TMVR device. We could offer TMVR for these patients, those patients with not so appropriate anatomies for an edge-to-edge therapy, because we've seen through what has been presented that the device work. The final mitral regurgitation rate is really impressive, virtual. If we get rid of that risk of LVOT obstruction, we can expect good clinical outcomes with the transfemoral access, as you said. Avoiding this transapical access is going to be beneficial for the patient potentially. So I think that we will need to get more experience with that. We will need to really keep the patient at the center of the equation, the anatomy of the patient, and try to accept that potentially for some patients, TMVR is going to be the best choice because the edge-to-edge is not going to be perfect. Durability of these devices is going to be another issue, and once we gather enough experience, we will be able to more precisely tailor such device or such therapy for our mitral regurgitation patients.
So Azim, the reason we're talking about valve replacement will be better repair using the edge-to-edge technology in the mitral position is that some of these patients still have residual mitral regurgitation afterwards. If you move from the mitral to the tricuspid position, we know that edge-to-edge repair is increasing the number of patients who's treating like this, but often the residual tricuspid regurgitation is much worse than what you see in the mitral position. So there may be an even bigger need for a valve replacement in that position. This is a pretty new therapy to do valve replacement in the tricuspid position. Maybe you can just enlighten us, what is the risk of these procedures? We know in the mitral position, we're talking about NEO-LVOT and the risk of LVOT obstruction, bleeding from the apex if you use a transapical approach and so on. But what is the risk in the tricuspid position?
Yeah. A great question. I just maybe take a little step back, Lars. Edge-to-edge therapies for the mitral has become pretty reproducible. We know who are the good patients. And the one thing with the mitral is we don't see these patients with these very large gaps, right? Tricuspid is different. Valve replacement is always going to play a role here because we see many patients who come to us who have already large gaps that we can't treat with edge-to-edge therapies. And so I think it's going to be an integral part of what we do. The risks and challenges are different to mitral, okay? And let's start with just from a sort of procedural point of view, and then we'll talk about some of the long-term issues. So from a procedural point of view and patient selection point of view, I think the important things to think about is the tricuspid annulus is much larger than the mitral annulus. And so many of these patients will need a very large valve, larger than what we currently have. I mean, the largest valve you saw we have with Intrepid is 48. And there's other companies that have 52, but often patients have larger valves than that or need larger valves than that. So that's one issue. The second issue is anchoring and where you anchor, whether you anchor on the annulus or the leaflets. Intrepid has the advantage of anchoring on the annulus and so doesn't need to anchor on the leaflets. There's no issues with RV alpha tract obstruction, so that's not an issue on the right side because the RV alpha tract's far away. But another issue is also the size of the right ventricle, and we don't think about that. Some patients have torrential atriogenic tricuspid regurgitation, massive atriums, and then with these tiny ventricles. And so the ventricle may not be large enough to accommodate the delivery system. And then the last part is the inferior vena cava. The inferior vena cava and where it comes off in relation to the annulus can have a huge impact on how easy it is to do the procedure or whether it's even feasible. There are some orientations of how the cava can come out that can make it impossible to implant a valve in a patient. That's procedurally. Then long term, there's so much we don't know about putting a valve on the right side. I mean, conduction system disturbances are going to be more frequent with valves. We don't know the exact frequency, but we know from surgery it's higher. Patients are probably going to need to be anticoagulated lifelong. It's a lower flow state, and so we need to know, we need to understand whether leaflet thickening or valve thrombosis. Durability is also going to be extremely important. And then the last part, which I didn't mention under procedure, is RV function and pulmonary pressures. Are there patients who are maybe better suited for repair rather than replacement because of their underlying RV function and pulmonary pressures, and maybe they have moderate RV dysfunction, and we wouldn't want to take away all their tricuspid regurgitation.
And what about the coronary arteries? Any risk of compression using radial force?
Well, we know the right coronary artery is pretty close. It's an issue for a tricuspid annuloplasty, definitely, or any device that needs to go into the annulus. It's more so an issue for tricuspid than mitral. So far with the valves, I have to admit, we've not seen any issues, but it's still early days. Let's remember, they've only been about 100, 120 patients worldwide done with some of these valves in total, right? So we're still very early on. There's a lot to learn still.
Okay. That was I think it was some great talks, great discussion here. I learned a lot. We have seen that the first transcatheter mitral valve replacement was done almost 10 years ago. It's been a slow move forward, but it seems that screening of patient selection, refinement of the devices, and now also moving towards a transfemoral transseptal approach is going to make the procedure even more safe and with good outcome for the patients. I think it's extremely exciting to see this valve is also now used in the tricuspid position, and looking forward how that's going to evolve during the next few years here. So again, thank you to the speakers. Thank you to you, Asim and TJ, for the discussion. And thank you for attending this session. Hope you're going to enjoy the rest of EuroPCR 2021.